So yes, we are here today to talk about hereditary pseudocholinesterase deficiency and succinylcholine. All right. So to start off, let's review some background. We have succinylcholine, which is a neuromuscular blocking agent that's widely used for anesthesia. Succinylcholine is rapidly metabolized by pseudocholinesterase, which is the enzyme encoded by the BCHE gene to inactive metabolites. Succinylcholine's duration of action is relatively short with quick on and quick off, with normal muscle function restored in about 10 minutes after discontinuation in patients with normal pseudocholinesterase activity. Succinylcholine is most commonly used to facilitate endotracheal intubation, electroconvulsive therapy, also referred as ECT, skeletal muscle relaxation during surgery or mechanical ventilation. And when used as a neuromuscular blocking agent, adequate sedation is critical to prevent patient distress and discomfort with this medication. In patients who have pseudocholinesterase deficiency, succinylcholine is not metabolized as quickly, leading to longer exposure to succinylcholine and prolonged neuromuscular blockade. In diving more into the enzyme, it's important to note that pseudocholinesterase is also called by several other names. You'll see in the literature plasma cholinesterase, serum cholinesterase, or butyrylcholinesterase. It is encoded by the BCHE gene, which is kind of where that butyrylcholinesterase name comes from. Its full physiologic role is not completely understood in the body, but the deficiency has been associated with adverse outcomes with succinylcholine in the literature. Pseudocholinesterase deficiency can be a result of both acquired and or inherited factors. So acquired factors are non-genetic factors that can cause enzyme deficiency. Another way to think about this phenomena is phenoconversion. So some examples of this include malnutrition, advanced age, malignancy, liver or kidney disease, pregnancy, burns, organophosphate poisoning, and certain medications. Others are inherited, where genetic variations can lead to either lower enzyme activity levels or dysfunctional enzyme activity. This can be broken down into two categories of either quantitative variants or qualitative variants, and we'll review those a little bit further in the next slide in more depth. So to date, over 75 BCT variants have been identified in the literature. As previously highlighted, these variants are classified into those two general categories, qualitative and quantitative. And to break this down further, qualitative variants are often in the coding region of the enzyme's active site and result in an enzyme with impaired function. So this is depicted here in the orange little Pac-Man figures. And then quantitative variants can arise in two different ways. The first is from a variant that causes serious structural modifications, resulting in little to no enzyme function. Examples of this could be an unstable enzyme due to a premature stop codon, resulting in a truncated protein. The second is due to a variant in the gene's regulatory region, leading to decreased protein synthesis. In either case, though, the end result is less enzyme overall. This is shown here in the red figure there. In the literature, BCHE has slightly different nomenclature than what we're used to with like the star alleles that we're most familiar with in the pharmacogenomics community. Instead, these letters are often used to represent variants. So the U here stands for usual, which is similar to a star 1 or wild type. The A stands for atypical, which is resistant to the dibukane inhibition test that we'll talk about in a little bit, and is a result of a missense mutation. The F stands for fluoride, which is resistant to sodium fluoride inhibition tests, and in general is rare across populations. A and F are both qualitative variants, though. H and J are also reported, but also are very rare in the population. K stands for kalo, which is a relatively mild reduction in enzyme concentration, but it is in high linkage disequilibrium with that A variant. And this is the most commonly reported variant in the European population, with up to potentially a 25% carrier rate that has been reported in the literature. H, J, and K are known to be the quantitative variants. S stands for silent variants, which is characterized by 10% or less of pseudocholinesterase activity. And to note, it's not just one S variant. There are multiple different variants that are all classified under this S because they have little to no function. Silent variants can either be qualitative or quantitative, just depending on that specific variant. And then not pictured are other rare variants, such as there's a C5 that's noted in the literature, which has increased pseudocholinesterase activity and has been associated with succinylcholine resistance in patients requiring a higher dose of succinylcholine. When looking at the clinical outcomes of this gene-drug interactions, most of the outcomes reported in the literature fall into these general categories. First is prolonged neuromuscular blockade, which can be in the magnitude of additional minutes to hours beyond that expected or normal duration. This can be presented as prolonged apnea or prolonged paralysis, and particularly with the prolonged paralysis, the psychological consequences of waking up and unable to move and the impact that has on the patient long-term. There's also the train of four monitoring, which is a diagnostic method used to assess neuromuscular blockade from succinylcholine. And this is typically performed in operating rooms or ICUs. This technique uses peripheral nerve stimulator to deliver 4 low voltage electrical impulses. And then that ratio of muscle twitch at time 4 versus time 1 determines that level of paralysis and that rate of recovery. Next, I'll turn it over to Jenny.
Thank you. And I'm going to switch over to a more historical perspective of this gene-drug pair. So interestingly, this gene-drug pair was one of the first pharmacogenomic identifications by Dr. Kayla, who is considered a founding father of pharmacogenomics. In the 1950s, he was one of the first to attribute the differences in pseudocholinesterase enzyme activity between individuals to inherited variations. He then proceeded to develop a biochemical assay to help distinguish the variant forms of the enzyme, which is still used today, and it's called the dibutane inhibition test. Dibutane is an anesthetic that has high affinity for the pseudocholinesterase enzyme and acts as a strong inhibitor. So therefore, when we see a greater than 70% inhibition, this is predicted to have a normal BCHE activity. While variations in the BCHE or the pseudocholinesterase enzyme will cause a lower affinity or for dibutane to the enzyme and reflect a lower percentage inhibition. So 30 to 70 is predicted to be heterozygous versus anything 0 to 30 is predicted to be homozygous. This test is a better predictor for the atypical variants, but can also help differentiate the other ones as well. Next, please. We're gonna touch base on some biochemical testing for this gene. Biochemical testing typically includes the dibutane inhibition test and or pseudocholinesterase activity testing. As you can see on the right-hand side, there are the reference ranges for each of these do vary by the laboratory. So we have a couple lab examples here for you to see. The assay is sensitive to different confounders that should be taken into consideration when evaluating the result that returns. These factors include administration of succinylcholine at the time of sample collection, storage temperature of sample, and if they had blood donation. It is recommended to do biochemical testing before succinylcholine or 24 to 48 hours after administration for more accurate reflection. Lastly, acquired factors can impact results specifically noted to by the laboratory, such as acute and chronic liver disease, chronic renal disease, organophosphate poisoning, pregnancy, and estrogen therapy. So all of these considerations are very similar to other biochemical testing, like for G6PD. Next, please. In regard to genetic testing, like many other pharmacogenomic testing, there is availability of genotyping as well as sequencing for this gene. For genotyping, the most common variants included are the following listed here, and the most common ones will be the A and K. Similarly to other genotyping panels, the variant coverage is limited and could miss rare novel variants. While sequencing would enhance the variant coverage and capture more common and rare variants, as well as potential variants of unknown significance. This method is commonly seen for prenatal carrier screening genetic tests that does include the pseudocholinesterase deficiency detection. So kind of look out for that if you do get any referrals for prenatal carrier screening results. Next, please. So unfortunately, none of the well-known pharmacogenomic guideline writing groups, such as CPIC or the Dutch Pharmacogenomic Working Group, have written a guideline for this gene-drug pair at this time, despite this have been around for such a long time. However, FDA does call it out in their drug label for succinylcholine in the warning and precaution section. So here's the paragraph that they have, and they are mentioning the risk of its use in patients with pseudocholinesterase deficiency. This can also be found in the Canadian labeling for succinylcholine. It is important to note that the labeling only mentions individuals who are homozygous for the atypical variant. So additional guidance for the other 75 and more variants is needed. In addition, the FDA table of pharmacogenomic associations includes succinylcholine, listing it as a concern for individuals who are BCAG intermediate or poor metabolizers, with the implication described as results in higher systemic concentrations and higher adverse reaction risk. Although the FDA calls out BCAG intermediate and poor metabolizers, these phenotype terminologies have not been well defined clinically. Next, please. However, we did run across this suggested genotype to phenotype table by Zhu et al. That describes the following phenotypes and the genotypes criteria for each and the corresponding clinical interpretation. This is a great starting point for future guidelines to take into consideration and adjust to better correspond to the specific guidelines, terminologies, and definitions in alignment with all the other guidelines. We do hope that to see a future guideline take this gene-drug pair into consideration to fill the current implementation gap of this significant gene-drug pair that is impacting people. And next, please. So that kind of concludes our didactic here. We wanted to let you all know that we did do a review of this gene-drug pair and have published it. So I'm going to share the article to you in the chat for reference. Thank you.